Welcome to the deep dive. Today, we're really getting into a heavy topic, cardiogenic shock. It's a critical medical emergency.
It really is.
We've gone through a stack of your sources, everything from management guides to, detailed nursing research. And our mission, as always, is kind of cut through the complexity, give you that shortcut to really grasping what this is all about. Now, here's something that jumped out. Cardiogenic shock, it isn't always this, dramatic collapse you might picture.
No, that's a key point.
What's really surprising and honestly a bit worrying is how subtly it can start or how fast it can progress. Makes spotting it early really tough.
Absolutely, and that's what we'll explore. This deep dive, it's not just about defining cardiogenic shock. We'll look at the causes, how it unfolds, and the treatments, which are incredibly complex, often life-saving. We'll also touch on the vital role of the care teams, especially nurses, in handling this, supporting patients, families. It's about understanding how they work to, bring the heart back from the edge.
Okay, let's unpack that. Cardiogenic shock. What is actually fundamentally happening inside the body? What's the core issue?
Right. At its heart, pardon the pun, cardiogenic shock is when the heart muscle is so damaged or stressed, it just can't pump effectively anymore.
Okay.
Its ability to contract and push blood out is severely impaired.
Okay.
So you get this inadequate supply of oxygen, not just to the body's tissues, but even to the heart muscle itself. Think of it like a major power failure for the body's main pump.
Power failure. Got it. So what causes this failure? Are there, different triggers?
Definitely. The sources break it down broadly into two camps, coronary and non-coronary causes.
Coronary and non-coronary. Okay.
So coronary cardiogenic shock, that's the more common one. You usually see it after a major heart attack, an acute myocardial infarction, or MI.
Right, a heart attack.
Specifically, when a big chunk of the left ventricle muscle gets damaged, that's the main pumping chamber. An anterior wall MI is particularly risky. If the left anterior descending artery gets blocked, you can get massive damage there. Basically, the muscle dies from lack of oxygen.
So that's a direct hit on the pump muscle itself. What about the non-coronary type?
Yeah, non-coronary causes are, more varied. It could be things that put immense stress on the heart muscle, even without a blocked artery. Things like severe lack of oxygen in the blood, hypoxemia or acidosis, really low blood sugar, low calcium, even attention pneumothorax, a collapsed lung putting pressure on the heart.
Wow, okay.
Or it could be conditions that just make the heart muscle function poorly, like cardiomyopathies, problems with the heart valves, fluid building up around the heart, cardiac tamponade, or serious heart rhythm problems, arrhythmias.
So either the muscle itself is damaged by a blockage, or something else is basically overwhelming it, pushing it into failure. That makes sense. But what happens then? The pump fails.
Yeah.
What's the immediate fallout in the body?
Well, this is where you see this cascade, this pathophysiological sequence kick in.
Mm-hmm.
The heart's output, its pumping ability, plummets.
Mm-hmm.
Stroke volume, heart rate, they either drop or get really erratic.
Okay.
And then, boom, blood pressure falls. Tissue perfusion, getting blood to the organs, is severely cut back.
So everything starts getting starved of oxygen.
Exactly. Vital organs, even the heart muscle that's still trying to work, they don't get enough blood. And here's the really dangerous part, the vicious cycle. That poor perfusion makes the heart even weaker. It can't pump effectively. So the ventricle doesn't empty properly when it contracts during systole. Blood backs up.
Backs up where?
Into the lungs. You get fluid buildup, pulmonary edema, making it hard to breathe. And this whole spiral, it can happen incredibly fast, hours sometimes, or it might build over days.
That sounds absolutely terrifying, like a positive feedback loop of failure.
It is.
So for someone going through this, or for the doctors, what are the warning signs? What does it look like?
Well, patients often show a mix of really distressing symptoms. They might have that crushing chest pain, angina. They can develop dangerous heart rhythms, arrhythmias. They often complain about just extreme fatigue.
Fatigue, okay.
And sometimes they express this feeling of doom, like they know something is terribly wrong. Plus, you see clear signs of hemodynamic instability, blood pressure all over the place, unstable vital signs.
That feeling of doom, that really hits home how serious this is. It's not just physical.
No, it reflects profound physiological distress.
So the team suspects it. What's the diagnostic process? How do they confirm it's cardiogenic shock and, figure out how bad the damage is?
It's a combination of things. Lab tests are crucial. They'll look at biomarkers like BNP, which indicates heart strain. They'll check cardiac enzymes and specific markers like troponin, CTNI, which show heart muscle damage. And serum lactate levels tell you about tissue oxygenation, basically, if the organs are suffering.
Okay, labs. What about imaging?
Imaging, too. A transthoracic echocardiogram, an ultrasound of the heart, can often be done right at the bedside. It gives a real-time look at how the heart's squeezing, how well it's functioning.
Like seeing the pump in action or inaction.
Exactly. And they'll do serial 12-lead ECGs, electrocardiograms, and often continuous ECG and ST segment monitoring. That lets them watch for ongoing ischemia, signs the heart muscle isn't getting enough oxygen.
Got it. So the diagnosis is confirmed. It's cardiogenic shock. What's the immediate plan? What are the top goals right then and there?
It's absolutely a race against time. The main goals are 1, limit any more damage to the heart muscle, 2, preserve whatever healthy muscle is left, and 3, improve the heart's overall function.
How do they do that?
Usually by trying to boost the oxygen supply to the heart muscle while reducing its oxygen demand. So doctors might aim to increase the heart's contractility, make it squeeze harder, or decrease the resistance it pumps against, that's the afterload, or ideally do both at the same time.
Right, supply and demand. But what takes priority? Treating the shock itself, the symptoms, or going after the underlying reason the heart failed?
That's a really key point. Like with any shock state, fixing the underlying cause is absolutely critical. You manage the symptoms, stabilize the patient, but you have to address the root problem.
So how does that play out depending on the cause?
Well, if it's coronary shock, usually from that heart attack, the focus is on restoring blood flow to the heart muscle. That might mean clot-busting drugs, thrombolytics, or maybe a procedure like PCI, percutaneous coronary intervention, like putting in a stent.
Angioplasty and stenting.
Right, or even coronary artery bypass surgery, CABG. Sometimes they use mechanical support devices too, like an IABP or a VAD, which we can talk more about. Often it's a mix of these things.
Okay, and for the non-coronary causes?
Then the treatment targets that specific issue. If it's a bad valve, maybe valve replacement surgery. If it's arrhythmia, medications or procedures to correct it. If it's acidosis or electrolyte problems, you correct those. Attention pneumothorax. You relieve the pressure.
So you fix the specific trigger.
Exactly. And here's something interesting. If the shock was triggered by a cardiac arrest, after they get the heart restarted, they might use something called targeted temperature management.
Cooling the body down.
Yeah, therapeutic hypothermia. Actively cooling the patient down to maybe 32 to 36 degrees Celsius. It's not really for the heart at that point. It's more about protecting the brain, improving neurological outcome after the oxygen deprivation.
Wow, that's unexpected. Cooling to protect the brain. Okay, so beyond fixing the root cause, what are the absolute first-line things they do, those immediate priorities?
Okay, immediate priorities are making sure the patient is getting enough oxygen, managing pain, and stabilizing their hemodynamics, their blood pressure, and circulation.
Let's break that down. Oxygen first.
Right. If their oxygen saturation drops below 90%, they get supplemental oxygen, usually starting with a nasal cannula, maybe 2 to 6 liters per minute. But they watch closely blood gases, pulse oximetry, how hard the patient is working to breathe. If that's not enough, they might need more support, potentially even mechanical ventilation. Breathing takes work, and that work stresses the failing heart.
Makes sense. What about pain? You mentioned angina.
Yes, if there's chest pain, IV morphine is often used. It does double duty, relieves pain, obviously, but it also dilates blood vessels.
How does that help?
Dilating veins reduces preload, the amount of blood returning to the heart. Dilating arteries reduces afterload, the resistance the heart pumps against, so it lessens the heart's workload.
Ah, clever.
But there's a catch. Some recent studies suggest morphine might interfere with antiplatelet drugs, which are also crucial after heart attack. So it's a balancing act, weighing the benefits against potential risks.
Always trade-offs. And hemodynamic stability.
Absolutely crucial. This usually means an ICU setting. They'll place an arterial line, a small catheter in an artery, usually the wrist.
Why?
It gives continuous beat-to-beat blood pressure readings, much more accurate than a cuff, and it allows for drawing blood samples easily without sticking the patient repeatedly. They might also insert a central line, a multi-lumen CVP catheter, or even a pulmonary artery catheter, a PA catheter.
Those sound more invasive.
They are, but they provide really detailed information. Pressures inside the heart chambers, how much blood the heart is pumping, cardiac output, the resistance in the blood vessels. It guides treatment decisions.
Got it. And fluids. I remember you said be cautious.
Extremely cautious. Yes, fluids are necessary, but you have to monitor very carefully. They might give small IV fluid boluses, slowly, incrementally.
Why slowly?
To see how the heart responds, trying to find the optimal filling pressure to improve cardiac output without overloading it. The big warning from the sources is, never give a rapid fluid bolus. In a failing heart, that can quickly lead to acute pulmonary edema, drowning in their own fluids, basically.
That's a critical point. Being careful with fluids in shock feels counterintuitive, but it makes sense here.
Absolutely.
So you're stabilizing, getting oxygen in, managing pain, monitoring closely, cautiously, using fluids.
Yeah.
What about the drugs that actually help the heart pump better?
Right. This is where vasoactive medications come in. These are powerful drugs used to try and restore adequate cardiac output. The goals here are usually to improve contractility, make the heart squeeze harder, decrease preload and afterload, lessen its workload, and stabilize the heart rate and rhythm.
Okay.
Now, improving contractility often increases the heart's workload, while decreasing workload might weaken the pump. They're kind of opposing actions.
So how do you manage that?
Often they combine two types of drugs, inotropic agents and vasodilators.
Inotropes and vasodilators.
Exactly. Inotropes boost the heart's contraction strength or heart rate. Vasodilators primarily reduce the afterload, the resistance the heart pumps against, lowering its workload and oxygen needs. They also reduce preload.
Can you give us some examples of these drug combos?
Sure, a common combination is dobutamine and nitroglycerin. Dobutamine is an inotrope. It stimulates beta receptors in the heart muscle, making it contract more forcefully, boosting cardiac output. It also has some effect on alpha receptors, which actually helps decrease resistance in the blood vessels, reducing afterload.
Okay, so the butamine helps the squeeze and eases the resistance a bit. What about nitroglycerin?
5-E nitroglycerin is primarily a vasodilator. At low doses, it mainly dilates veins, reducing preload. At higher doses, it also dilates arteries, reducing afterload. So putting it together with dobutamine, you get increased output, but you're also actively lowering the workload. Plus, the vasodilation helps get more blood flow to the heart muscle itself through the coronary arteries.
That's a smart combo. Any other key drugs?
Dopamine is another one, but it's dose-dependent and tricky.
How so?
At lower doses, say 2 to 8 micrograms per kilogram per minute, it can improve contractility and slightly increase heart rate, boosting output. But, and this is critical, at doses higher than 8 miscmin, its main effect becomes vasoconstriction, clamping down blood vessels. That increases afterload and makes the heart work harder, which is exactly what you don't want in cardiogenic shock.
So the dose has to be just right.
Precisely. Careful titration is essential. They're constantly adjusting based on the patient's response. And another thing, you often have to correct severe metabolic acidosis, which develops in later shock stages. If the body is too acidic, these vasoactive drugs just don't work as well.
Right, the internal environment matters.
Definitely. And there are other vasoactive drugs they might use, norepinephrine, milrinone, vasopressin, others. They all work on different receptors in the sympathetic nervous system, often used in combination, tailored to the patient. But they all have potential side effects, too. And they might use diuretics like furosemide to help get rid of excess fluid and reduce the heart's workload that way.
It really is a complex balancing act with these medications.
Yeah. What about the heart rate and rhythm itself? Is that managed separately?
Oh, yes. Serious arrhythmias are really common in shock. It can be due to the lack of oxygen, electrolyte imbalances, the acidosis, all sorts of things.
Okay.
Plus, the body's natural response to low blood pressure is often to speed up the heart rate. But if it gets too fast, the heart doesn't have enough time to fill between beats. Diastole gets too short. So a very fast heart rate can actually worsen cardiac output.
Paradoxical.
Exactly. So antiarrhythmic medications are often needed to control the rate and stabilize the rhythm. Too fast is bad, irregular is bad.
This is incredibly sophisticated, managing all these variables.
Yeah.
But what if it's not enough? What if the drugs, the fluids, the rhythm control, they just can't turn it around?
Yeah. That's when you move to mechanical assistive devices. These are machines designed to temporarily take over some of the heart's pumping work. They act as a bridge, maybe a bridge to recovery, or a bridge to a more definitive treatment like transplant.
Mechanical support, what does that involve? One of the most common is the intra-aortic balloon pump, or IABP.
I've heard of that. How does it work?
It's basically a catheter with a long balloon on the end. It's usually inserted through the femoral artery in the leg and threaded up into the aorta, the big artery leaving the heart. The balloon inflates and deflates in sync with the heartbeat, usually timed off the ECG.
Okay. Inflating and deflating. How does that help the heart?
It's pretty clever. The balloon inflates during diastole when the heart is relaxing and filling. This increases the pressure in the aorta during diastole.
Why is that good?
That increased pressure pushes more blood backwards into the coronary arteries, which branch off right near the heart's exit. So it improves blood flow to the heart muscle itself. It also boosts blood flow down to the rest of the body.
Okay, so inflation helps feed the heart. What about deflation?
The balloon deflates rapidly just before systole, just before the heart contracts to pump blood out. This sudden deflation creates a kind of vacuum effect, momentarily lowering the pressure in the aorta right as the left ventricle is about to eject blood.
So it reduces the resistance the heart has to pump against?
Exactly. It decreases that afterload, making it easier for the weakened ventricle to push blood out, so it reduces the heart's workload while improving its own oxygen supply. It's short-term support, usually just for days.
That is ingenious. Are there other devices?
Yes, for more severe failure, there are ventricular assist devices, or VADs. These are pumps that can help either the left ventricle, the right ventricle, or sometimes both. There are even temporary total artificial hearts. And in really extreme emergency situations, they might use extracorporeal devices like ECMO, extracorporeal membrane oxygenation. It's similar to the heart-lung bypass machine used in open heart surgery.
Yeah.
It oxygenates and pumps the blood outside the body, basically giving the heart and lungs complete rest, usually as a bridge to something like a transplant.
Wow. These are really advanced intensive interventions. It's clear managing this takes a huge team effort. The sources spend a lot of time on nursing care specifically. What's the nurse's role in all this complexity?
It's absolutely central and incredibly demanding. The nurse is often the one constantly at the bedside, integrating everything. Their role covers prevention, monitoring, giving meds and fluids, managing these complex devices like the IABP, and ensuring safety and comfort.
Let's start with prevention.
Well, ideally, identifying patients at risk early on, promoting good oxygenation, trying to reduce the heart's workload by conserving the patient's energy, treating chest pain quickly, giving oxygen. But realistically, cardiogenic shock often just happens. It can't always be prevented.
Yeah.
So then the focus shifts intensely to preventing it from getting worse and trying to restore function.
Okay, so monitoring must be huge.
Absolutely massive. Nurses manage the arterial lines, the ECG monitoring, making sure the equipment is working correctly, interpreting the readings. They have to anticipate what might be needed next, which drugs, fluids, equipment, and have it ready. They document everything meticulously and are the first to report subtle changes in the patient's status, hemodynamics, breathing, heart rhythm, lab results, how the patient looks and feels. They're the eyes and ears at the bedside.
And administering all those complex meds and fluids we talked about.
Yes, safely and accurately. Constantly watching for side effects like blood pressure dropping after morphine or nitroglycerin. Checking for sites, especially for those potent vasoactive drugs, if they leak into the tissue, they can cause serious damage, necrosis. That's why central lines are preferred.
Right.
They monitor urine output closely. Kidney function is often one of the first things to suffer in shock. They track electrolytes, kidney function labs like BUN and creatinine. And they're always assessing for fluid overload, listening to the lungs for signs of that pulmonary edema.
What about managing devices like the IABP?
That requires specific training. The nurse often makes fine-tuning adjustments to the timing of the balloon inflation and deflation, synchronizing it perfectly with the patient's own heart rhythm to get the maximum benefit. And because the catheter is usually in the femoral artery, they have to constantly check the circulation in the leg on that side, pulses, color, temperature, because there's a risk of cutting off blood flow to the limb.
So much vigilance required. And what about basic comfort and safety?
Still vital, even with all the high-tech stuff. Managing pain, preventing infections at all those IV line sites, protecting the patient's skin from breaking down because they're so ill and immobile, positioning them carefully to help with breathing and comfort, trying to reduce anxiety. It's holistic care amidst a crisis.
It sounds incredibly comprehensive. And what about the family? This must be terrifying for them. How does the nursing role extend to them?
That's a hugely important part of it. Nurses often act as the main communicators, providing brief, clear explanations about what's happening, what the procedures are for, using simple touch, reassurance. Families are usually incredibly anxious. They need opportunities to see the patient, talk to them if possible. They need repeated explanations of the treatments, how the patient is responding. It helps them cope.
That human connection seems crucial.
It is, and the sources emphasize this evolving understanding in critical care. Evidence-based guidelines stress frequent communication, creating a welcoming environment for families, flexible visiting, maybe even overnight stays, and involving patients and families in decisions when possible. Research actually shows that when families feel engaged in care, they feel they're contributing to the patient's emotional well-being, which is powerful. It's not just about fixing the heart, it's about caring for the whole person and their support system.
What an incredibly thorough deep dive. From that first domino falling in the body, through the complex drugs and machines, right up to the vital role of the nursing team and family. It's clear that managing cardiogenic shock is just a monumental task. Hopefully you feel like you've got that shortcut now, a better handle on this really complex emergency that honestly could affect anyone.
Yeah, we've seen how doctors and nurses meticulously support that failing pump using everything from fine-tuned medication drips to sophisticated machines like the IABP. Every detail matters: how fast you give fluids, the exact timing of that balloon pump,
Hmm.
and that human element, the family support, the compassionate care in the ICU, that really brings it all together, doesn't it?
It really does. So as you think about everything we've covered, here's something to mull over. We've talked about how cardiogenic shock can hit suddenly, unexpectedly. And the response requires immediate, intensive, high-tech resources, those mechanical devices, the ICU beds, the specialized staff. Given that complexity and the resource intensity, especially for interventions like IABP or VADs, that might only be short-term bridges, what might be the ethical considerations around allocating these high-cost, high-tech resources in critical care, especially when demand can surge unpredictably? What does it really mean for our healthcare systems to be truly ready for the unexpected critical event? Something to think about. Thank you for joining us on this deep dive. We hope you feel more informed and maybe even more curious than ever.